Assalamualaikum warahmatullahi wabarakatuh and good morning everyone. Thank you, the chairperson, for the kind introduction. I would like to also thank the organizing committee for inviting me to speak today at the 5th Asia Pacific Prader-Willi Syndrome Conference on the topic of endocrinology care in Prader-Willi syndrome. This is my plan of talk. I'm going to talk to you on the problems of growth disorder, followed by hypogonadism, hypothyroidism, and hypoadrenalism. We all know about Prader-Willi syndrome, and I think you are the best person to describe to me what is this. So, as we know, Prader-Willi syndrome patients have this lack of expression of genes on the paternally derived chromosome 15q11 to q13 and lead them to have these characteristic phenotypes, which are severe neonatal hypotonia, early onset hyperphagia, development of short stature, learning disability, and behavioral problem. Now let us look at the metabolic and endocrine dysfunction in Prader-Willi syndrome patients. As we know, PWS patients have problem with their hypothalamic pituitary dysfunction that leads to metabolic problems. In this group of patients, there will be no satiety, and because of that, they have insatiable appetite that will lead them to obesity, morbid obesity, as well as progressive obesity. And this will then lead them to have glucose intolerance and cardiovascular disease in a later life, which include having problem with hypertension and hyperlipidemia. In this group of children, they also have hypothalamic pituitary dysfunction that leads to the endocrine abnormalities, which include growth dysfunction, hypogonadism, hypothyroidism, and hypocortisolism. And in this talk, I will just concentrate on the problem of endocrine abnormalities. So now let us move to the growth disorder. If we look at growth and growth hormone status of Prader-Willi syndrome patients, in the early stage of life, they already have some issues whereby they will have mild prenatal growth retardation. Most of them has the median birth weight of minus 1.37 standard deviation with median birth length of minus 0.46 standard deviation. As they grow up to about 2 years, a number of them may have problem of short stature, and this is due to the low IGF-1 in the majority of them. And if we were to do growth hormone stimulation test in this group of children, about 40 to 70% of them do have growth hormone deficiency. Now, if we look further into their growth, at the median age of about 6.4 years, their median height SDS is about minus 2.2 standard deviation, with mean spontaneous adult height of about 162 centimeter in boys and 150 centimeter in girls. This is because of the combination of growth hormone or insulin-like growth factor 1 deficiency as well as lack of pubertal growth spurt. If you look at this table, if we look at those PWS patients at their final height in the European and American countries, if we look here, the average final adult height for male is about 155 to 162 centimeter, and the final adult height for female is about 148 to 149 centimeter. If we look at Japan, among the Japanese PWS, the final adult height for male is only about 148 centimeter, and for female 141 centimeter. And because of that, there is an indications for the use of growth hormone in this group of children. In the USA, it has been approved since year 2000, in Europe year 2001, and in Australia in year 2004. Before we move on and talk about the growth hormone therapy, let us just look at the growth hormone physiology. Hypothalamus will produce the growth hormone releasing hormone that will stimulate the anterior pituitary to produce growth hormone. growth hormone from anterior pituitary will stimulate the liver to produce IGF-1, which is the insulin growth factor 1. Growth hormone that is being produced by the pituitary can also have a direct effect on the bones. So the IGF-1 effect on the muscle is that it increases the lean tissue as well as energy expenditure together with increase in amino acid transport. At the adipose tissue, IGF-1 will increase the lipolysis, reduce glucose transport, and reduce lipogenesis. At the bones, the IGF-1 will increase the bone mass as well as promotes epiphyseal growth, and this will lead to linear growth and bone metabolism. So if one do not have growth hormone production, that means the IGF-1 will be low. With low IGF-1, there will be reduce in muscle mass and there will be an increase in waist-hip ratio. At the adipose tissue, there will be increase in body fat mass as well as atherogenic lipid profile. While at the bone, there will be a reduction in bone mass as well as growth failure. When we talk about growth hormone therapy in Prader-Willi syndrome, there need to be a multidisciplinary team who manage this group of children. And usually the coordinator is a pediatric endocrinologist. The other team members include the geneticists, the NT specialists who will look into the upper airway obstructions, which is the tonsils and the adenoids, the respiratory physician who will look into the sleep study related to the obstructive sleep apnea, spine specialists who will look into the scoliosis problem, nutritionists as well as rehabilitation specialists that will look into the muscle strength and scoliosis management. Now let us look at the indications for the use of growth hormone therapy in Prader-Willi syndrome patient. The main indication is basically because of poor height gain and also poor muscle strength or delayed motor development, with the aim to improve psychomotor development, growth during childhood and attain normal adult height, as well as to improve body composition. So what are the exclusion criteria? Prader-Willi syndrome patients who have severe obesity, uncontrolled diabetes, untreated severe obstructive sleep apnea, active cancer, and active psychosis should be excluded from getting growth hormone therapy. Scoliosis and cognitive impairment should not be considered as a contraindication to start growth hormone therapy in this group of children. So what are the challenges? The challenges are basically we are treating individuals with cognitive disability with very therapeutic goals that are not focused exclusively on the increased height, and the challenges of having a potential life-threatening adverse events in starting Prader-Willi syndrome patient on growth hormone therapy. So when do we start? There is no consensus on the age of growth hormone start for Prader-Willi syndrome patient. However, it is recommended that we start growth hormone therapy before the onset of obesity, that is before 2 years of age. And the current evidence tells us that we should start them at a young age, even at a 4 to 6 month old, to improve motor development, muscular tone, as well as cognition. What about the dosing? Previously, the dosing that we start in children with Prader-Willi is at 9 to 12 microgram per kilo per day, with a standard dose of 25 to 35 microgram per kilo per day. The current recommendation is that to start them on 0.5 milligram per meter squared per day, with a standard dose of 1 milligram per meter squared per day, and these doses is adjusted based on the growth response or the IGF-1 levels. So let us talk about the benefits of growth hormone therapy in Prader-Willi syndrome. From KICS data, looking at the pre-pubertal height gain of about 522 children, and when they look at the mean height at the start of minus 2.05 standard deviation, but after 3 years, the height has improved to just minus 0.31 standard deviation. And KICS data looking at final adult height among 173 Prader-Willi syndrome adults have shown us that the final adult height or the near adult height is only minus 1.19 standard deviation compared to the start, which was minus 2.14. So here I'm just showing you the table of the comparison between children or young adults who have been treated with growth hormone compared to the historical data. As you can see from here, for the male final adult height with the use of growth hormone, the mean final adult height is about 170 centimeter compared to 155 to 162 centimeter in those who were not treated with growth hormone. And if you look at the female, the mean final adult height is 155.8 centimeter compared to just about 148 to 150 centimeter for those who were not treated. Alright, this table is just to show you the difference in the final adult height compared to baseline. As you can see from here, if we look at the height at baseline of minus 2.1, 1 year later is at minus 1.2, and at start puberty, which is very good, at minus 0.2. However, at the final adult height, the height SDS was only about minus 1.2 compared to at the start of puberty. And this difference is mainly because of the lack of pubertal spurt in this group of children. What about other benefits? So if we look at the body composition, motor function and fat mass, it has been shown with the use of growth hormone, there is a decrease in percent body fat in first year and stabilization in second year and onwards. There's also increase in lean body mass during the first 2 years, improved physical strength and agility, decreased subcutaneous fat volume, lower visceral fat and thigh fat, as well as increase in HDL and reduce in LDL cholesterol. The other benefits include better cognitive performance. Among 127 children aged between 4 to 21 years in the USA, it has been shown that growth hormone therapy improved cognitive performance, improved the verbal and composite IQ scores with better communication and better daily living skills. And this group actually suggested that earlier is better, whereby starting before 12 months had higher non-verbal and composite IQ score compared to those started by the age of 1 to 5 years. The other benefits include bone mineral density. The Dutch Prader-Willi syndrome cohort have shown us that among 77 prepubertal children treated for 4 years with growth hormone and 64 pubertal children treated with growth hormone for 9 years, they have shown that prepubertal BMD increased significantly. However, for pubertal children, BMD decreased significantly but still within normal, significantly associated with the pubertal development. So they conclude that clinicians should start sex hormone therapy from the age of 11 years in girls and 14 years in boys, unless there is a normal progression of puberty to avoid the problem of lack of bone mineral density. This graph is just to show you what I've mentioned earlier. If you look at the right side, so there is an improvement in BMD at the prepubertal age, whereby after these children goes into the pubertal stage, the BMD start to drop. So what about other outcomes? The safety study up to 8 years have shown that growth hormone therapy is safe and growth hormone use in Prader-Willi syndrome remains supportive. And if you look at the scoliosis progression, there is no change in scoliosis progression in children with Prader-Willi treated with growth hormone. And if we look at the cardiovascular system, growth hormone treatment has shown an improvement in the CVS risk. Although I have shown you the benefits of growth hormone, there are still warnings if we were to start growth hormone therapy in Prader-Willi syndrome, and these include sleep apnea with a high risk of death during first 9 months, and upper airway obstruction due to adenoid and or tonsil hypertrophy, severe respiratory impairment, as well as changes in glucose tolerance, whereby This can be due to the impact OGTT, oral glucose tolerance test, prior to treatment, those who are obese, or those with strong family history of diabetes. What about other adverse outcomes? Death in Prader-Willi syndrome after growth hormone is mostly related to respiratory disordered breathing and associated infection. That is the reason that these patients need to be monitored very closely by the endocrinologist, respiratory physician, and the ENT doctor. So an ongoing debate on the use or not to use growth hormone in children with Prader-Willi syndrome who have OSAS or have problem with respiratory muscle impairment is still ongoing. So what do we do before we start growth hormone therapy? So before we start growth hormone, there is a need for a genetic confirmation, nutritional evaluation and body composition, together with looking at the control of food, especially if these children are already obese. There's also a need for a complete clinical evaluation of sleep and breathing, whereby the ENT assessment and polysomnography are mandatory if there is any snoring or enlarged tonsils. Before we start growth hormone therapy, there is also a need to evaluate IGF-1 level. However, growth hormone stimulation testing is not required as part of the therapeutic decision-making process. Oral glucose tolerance test should be done in those who are obese or more than 12 years old with family history of diabetes. Scoliosis evaluation is important, and they also need to be evaluated for problem of hypothyroidism and hypoadrenalism. While on growth hormone treatment, these children have to have a close clinical assessment of their height, weight, BMI, and body composition, together with scoliosis, and also looking at the adverse events every 3 to 6 months. About 6 to 12 monthly, IGF-1 needs to be looked at, and to avoid IGF-1 more than +2 standard deviation score. Fasting glucose, HbA1c, and OGTT needs to be done if there is any history of previous impaired glucose tolerance tests, obesity, or strong family history of diabetes, and in those children who are more than 12 years. Yearly thyroid function is important, and lipid profile as well as liver function and ultrasound of the liver is needed to look for non-alcoholic fatty liver disease. An ENT assessment and polysomnography has to be done within the first 6 months, and worsening sleep disordered breathing or snoring, enlarged tonsils and adenoids is an indication for a mandatory ENT assessment and polysomnography. X-ray as well as orthopedic assessment is important to look for scoliosis, and yearly bone age is needed. Clinical assessment of body composition every 6 to 12 months by one or more of the following are recommended, and these include looking at waist circumference, skin fold thickness, as well as DEXA. This is just to show you what we are doing in our clinic in terms of the monitoring schedule. So when do we stop growth hormone? We need to stop growth hormone therapy if there is any uncontrolled progression of obesity, worsening glycemic control despite weight control, diabetic medication, and normal IGF-1 level. There is worsening sleep disordered breathing despite weight control, tonsillectomy or adenoidectomy, as well as normal IGF-1. And we need to stop if there is already an attainment of adult height if growth hormone therapy is given due to the short stature or due to the growth hormone deficiency. This is just to give you a summary of the algorithm for growth hormone treatment in Prader-Willi syndrome patient, as I have shown you earlier, whereby there is a need for a genetic confirmation as well as a polysomnography, and if there is any sleep disordered breathing, you need to refer to ENT and follow the patient and put the patient on CPAP. If there is no sleep disordered breathing, these patients can be start on growth hormone therapy, but there is still a need to monitor for any obstructive sleep apnea, and also the need to uh, to have the OSA study, the polysomnography, and check the IGF-1 along the way. So all this needs to be done and monitor every 3 to 6 months, and then annually, basically looking for any problem with sleep disordered breathing along the way. Let me just show you some cases that we have treated with growth hormone therapy. So ZA is a boy who was born in 2010 with birth weight of 3 kilograms. He had neonatal hypoglycemia, hypotonia, and right undescended testes. He was diagnosed with Prader-Willi at the age of 6 months, and at the age of 11th month, he was referred to me for the start of growth hormone therapy, where at that time he was only 7 kilograms with a length of 66.9 centimeter. He had a very poor head control, was floppy, and his development age at the age of 11th month was only 5 months. He was started on growth hormone therapy at 12 months, and here I'm showing you a picture of him at 6 years, 8 years, and 10 years after starting growth hormone therapy. Another girl, TKL, was also born in 2010 with a birth weight of 2240 grams. She was hypotonic and had poor feeding. She was ventilated for pneumonia at the age of 2 months old. So she was diagnosed with Prader-Willi at the age of 2. She was only referred to me at the age of 16 months for growth hormone therapy. At that time, she was 6.45 kilograms with a length of 72.6 centimeter. She had a very poor head control and very floppy with mild scoliosis. However, there was no obstructive sleep apnea, and the overnight saturation oxygen monitoring showed no desaturation. She was started on growth hormone at the age of 19th month and increasing slowly, and the head control and the motor power or gross motor power after 2 months was really improved. This is her picture 9 years later. She is currently attending a normal school. So what about growth hormone therapy in Prader-Willi syndrome adults? So the indication basically for those who have growth hormone deficiency with the aim to improve body composition, lipid metabolism, physical and psychosocial functioning, as well as improve the cognitive function and quality of life. Before starting growth hormone, there's a need for genetic confirmation and expert multidisciplinary evaluation together with evaluation of the growth hormone IGF-1 axis. The treatment with growth hormone must be in the context of appropriate dietary, environmental, and lifestyle interventions necessary for care of all patients with Prader-Willi syndrome. So the dose is quite small compared to children at 0.1 to 0.2 milligram per day based on the age, presence of edema, prior growth hormone exposure and sensitivity, and concomitant oral estrogen use. So subsequent dosage titration should be based on the IGF-1 level and try to keep the IGF-1 below 2 standard deviation. IGF-1 level should be maintained within the upper part of normal range for healthy age-matched normal individuals. And the study that was done by the adult Prader-Willi syndrome Scandinavian group have shown that among 46 of these adults randomized to growth hormone versus placebo for 1 year and followed by open label for 2 years have shown us that after a year, IGF-1 increased by 1.5 standard deviation. There is a reduction in visceral fat, subcutaneous fat, and thigh fat. There is an improvement in thigh muscle, as well as increase in lean body mass and decrease in total fat mass among adults who were given growth hormone therapy. So when to stop for adults? For adults with Prader-Willi and growth hormone deficiency, treatment duration depends on primary clinical outcome, basically looking at the body composition, lipid metabolism, physical and psychosocial functioning. And we have to also look at the occurrence of side effects, that is the impairment of glucose metabolism, edema, or even heart disease. This is just to show you the typical features of the growth hormone deficiency in Prader-Willi syndrome newborn, at childhood and mid-adolescence, as well as in adult life, as I have clearly mentioned to you earlier. So now let us go and look at the other endocrine problems in Prader-Willi syndrome, which include hypogonadism. So if we look at hypogonadism in Prader-Willi syndrome males, uh, almost 66 to 100% of newborns have either unilateral or bilateral cryptorchidism, and almost all require orchidopexy. Human chorionic gonadotropin treatment has been used in this group of children to lower the testicular position and improve development of the scrotal sac and growth of phallus length. If you look at the penile length, most of them has normal penile length at birth and in early childhood. However, the penile length starts to fall below -2 standard deviation as they grow older. This group of children goes into the normal mini-puberty of infancy within the first few months of life, followed by decrease in testosterone and the gonadotropins to prepubertal levels. At the onset of puberty, testosterone levels increase but remain low. The LH levels remain low normal to normal, while the FSH increases and remains normal to high. Most of the males have normal age of onset of puberty, but an arrest of pubertal progression occurs at tenor stage 3, coinciding with testicular failure. Testicular size may progress to a volume of 6 to 7 milliliters and remain small into adulthood. Prader-Willi syndrome males are generally infertile, with no known reports of Prader-Willi syndrome males fathering a child. Inhibin B, a marker of spermatogenesis and Sertoli cell function, is low or undetectable in most adolescents and adults, which is when testicular failure is most evident. At present, there is no consensus exists as to the most appropriate regimen for pubertal induction or hormone replacement in males, so the dosing and timing should reflect the normal process of puberty. Treatment with testosterone replacement is recommended for Prader-Willi syndrome males with delayed or incomplete puberty, usually by the age of 15 to 16 years, and it is recommended that they be given intramuscular testosterone replacement starting at a dose of 50 to 100 mg every 28 days with gradual increase towards typical adult male doses. Careful monitoring of the growth and skeletal maturation needs to be done. Once males are at the adult doses, other forms of testosterone administration can be considered, including testosterone patches or gel. And we have to beware of the increased risk of behavior issues and aggressive outbursts in this group of males. So what about females? Up to 76% of females with Prader-Willi are born with hypoplasia of the external genitalia with labia minora and clitoral hypoplasia. At the onset of puberty, which is a breast development, this occurs typically at a normal age, but the progression to tenor 3 and 4 is usually delayed, and very few of them reach tenor stage 5. Most do not progress to menarche, although 8 to 25% has spontaneous periods. The average age of reported first period is late but varied, occurring at an average age of 20 years, and almost all have had oligomenorrhea after menarche. For females, they do have low to low normal estrogen and LH levels, but their FSH levels are more variable after pubertal onset, from low to normal to high, indicative of mixed central and primary defects. Inhibin B, if measured, is low in most adults. A subset may have progression or preservation of fertility, and inhibin B levels of more than 20 correlate with the potential for fertility. At present, there are 6 documented pregnancies with females who have 15q11.2 to q13 deletion have a 50% chance of mothering a child with Angelman syndrome. Therefore, it is important to counsel female patients on reproductive health and contraceptive practices. At present, there's no formal guidelines for hormone replacement in females with Prader-Willi syndrome. The usual practice is that we need to monitor females clinically for spontaneous initiation and progression of puberty. If no breast development occurs by the age of 13 years, pubertal progression stalls or no menarche by the age of 16 years, then hormone replacement is started. Oral estrogens at graduated doses are typically used for initiation or continuation of stalled puberty. Combined oral contraceptive pills are used after the first menstrual bleed that has occurred. For both males and females, premature adrenarche has a prevalence of about 14 to 30%, and adrenarche may be associated with advanced bone age in some cases. Premature adrenarche in Prader-Willi syndrome is typically not rapidly progressive or associated with other signs of central puberty, and it is generally felt to be benign. This is just to show you the typical development of the hypogonadic phenotype in Prader-Willi syndrome patient in newborn, childhood, as well as adult life, as I have explained to you earlier. So now let us look at hypothyroidism. Central hypothyroidism have shown to be increased in this group of children with a prevalence of 20 to 30%. However, there are other reported prevalence of just 2 to 4%, which is no different from healthy controls or the general population. There is no significant difference between TSH and total T4 levels on newborn screening compared to healthy controls. And TSH alone for newborn screens may not be enough to rule out hypothyroidism. There is a higher rate of central hypothyroidism in the first 2 years of life, whereby there is low free or total T4 levels with normal TSH. So, expert consensus have suggested to screen for hypothyroidism within the first 3 months of life and then yearly, especially if they are on growth hormone therapy, because growth hormone increase conversion of T4 to T3. And for the treatment-wise, L-thyroxine is typically replaced dependent on the age and weight of the child if thyroid function is indicative of hypothyroidism. So lastly, let us talk about the hypoadrenalism. So central adrenal insufficiency has a reported prevalence of 0% to 60%, and the true prevalence is still unclear due to different testing methods. Currently, there is no guidelines or recommendations on the appropriate evaluation and management of central adrenal insufficiency. Clinicians should maintain a high index of suspicion for CAI across the lifespan in Prader-Willi syndrome individuals. It is recommended that empiric treatment with glucocorticoids during anesthesia or major surgery is given, as well as stress dose steroids for all patients during physical stress or illness, including mild upper respiratory infections. A good practice is to assess for CAI by routine testing methods prior to any major surgery or procedure requiring anesthesia, and to treat with perioperative steroids empirically if normal adrenal function has not been documented. If CAI is detected, typical glucocorticoid replacement of 30 to 50 mg per meter squared per day during mild or moderate illness divided 3 times daily should be given, and 75 to 100 mg per meter squared per dose given immediately prior to major surgery or anesthesia. The caution is to avoid overtreatment due to the risk of obesity and poor bone mineral density. It is still unclear or uncertain which test is optimal for assessment of CAI and whether there's a need for ongoing or repeat testing over the lifetime. So, ladies and gentlemen, I have shown you earlier about growth hormone therapy, hypoadrenalism, hypothyroidism, and hypogonadism in Prader-Willi syndrome children. So, growth hormone therapy in children with PWS have shown improvement in the overall physical appearance, growth, BMI, and strength, improved body fat and lipid metabolism. However, there is no change in glucose tolerance. And early use of growth hormone improves cognitive function and IQ scores. Pre-growth hormone and ongoing assessment is necessary to ensure healthy benefits and reducing adverse events. Hypogonadism is a common finding, leading to complete or partial pubertal failure due to insufficient secretion of the pituitary gonadotropins LH and FSH, as well as gonadal side steroids. Hypothyroidism is a common finding, approximately 20 to 30% of children in PWS, and it is thought to be central in origin. Children and adults with Prader-Willi syndrome are at risk for central adrenal insufficiency, which has been detected in about 60% of cases. So, ladies and gentlemen, I have shared with you the endocrine problems and care in Prader-Willi syndrome patient, and I'm happy to take any question. Thank you very much for your attention.